I'd like to emphasize the complications, but not all of them. You will see that we are going to address mostly the hypoparathyroidism and what we do for the recurrent nerve by using the intraoperative neuromonitoring system, and then we will have an adjourn. There is like an epidemic of thyroid cancer. This is what we see in all of our countries, but whether it is related to radiation or to the epidemic of the use of ultrasound, we really do not know, but we have an incredible increase in thyroid cancer, which is true for Turkey, which is true for Georgia, which is true for all the other countries, but even the mortality is very stable. We see that there is an increase not only in the papillary microcancer, but also in those cancers which are pronounced as T2 cancers as well. Epidemiologically, in Turkey, we have an incredible increase. The highest incidence for the lady is thyroid cancer in Turkey, and today it has been positioned on the second level after breast surgery, and that's why we try to be very keen on the management of this type of surgery. Even we have no screening program like that was true for Korea, for example. Even we have no screening program for thyroid cancer. Thyroid cancer has been situated on the second level for the lady, and this is still increasing. I see on this chart that it's also true for Georgia as well. Even the rise of incidence of thyroid cancer is not that high as in Turkey. It's high in Georgia as well. It's also true for other countries throughout the world. We are talking about a very tiny organ, but a lot of things change during the time. And there is an enormous paradigm shift regarding the diagnosis, the treatment, the follow-up, and the prognosis. I will try to address more the treatment. Because of this, nearly every society has published its own guidelines, which is there for the Turkish specialists as well. And I know that you also have a very new recent published translation of the ATA guideline, which of course is one of the most preferred guidelines in the world. All of these guidelines state that today less is better. What we do is we do less FNABs, fine needle aspiration biopsies, we carry out less surgery, or we have changed the strategy of surgery from total to hemithyroidectomy in a kind of patient, I will tell you. But we definitely use less radioactive iodine ablation today. Why is this change? Because in the past, randomized trials were very rare and robust evidence for or against a treatment were not frequently available for early and advanced thyroid cancer. So we relied more on expert opinion regarding the experience. But today we have evidence-based data, even not very high, but this we see serves us for the quality improvement of the case. Today, we know that we have a long-term outcome with thyroid cancer because most patients are dominated by the papillary thyroid cancers. It's very important to assess not the risk of death anymore, but we talk about the risk of recurrence. So the patients do not die from this disease, but they have to be under follow-up. The prognostic factors are very clear today, and the use of prognostic systems for certified management is important. But what we have realized during this time, during this paradigm shift, that the routine current systems which we had used until today have poor individual response and poor recurrence prediction. So it's totally different. That's why we need new predictive parameters for describing not the death, but the recurrence. So the ETA, the European Thyroid Association, has described the risk stratification, which also have been used by the ATA guidelines, where the patients are classified in three: very low risk, high risk. So it's very important to put your patient in one of these. For example, a patient with unifocal microcarcinoma, where a complete surgery had been carried out. A complete surgery doesn't mean total thyroidectomy here. That's important to underline. But a patient without lymph node metastasis is a patient with a very low risk. This we see in this chart, which is also originated from the ATA guidelines, and we all use this, and we do describe the risk of the patient. For example, here we have again a unifocal papillary microthyroid cancer, which is at the very bottom. But what is very high? This is follicular thyroid carcinoma, for example, with extensive vascular invasion. But on the other hand, even when we try to put the patients in one of these phases, it's very important to know that it's very dynamic. You may have excellent response, but it may change to intermediate response or incomplete response. So we have to know that during the follow-up, regarding the biology of the tumor, which we really do not know that well, the risk stratification can change for the patients. So what has changed regarding the, what has changed regarding surgery? Today, we are not talking total thyroidectomy for all thyroid cancer cases. In my very initial years during my residency, if the patient received a diagnosis of thyroid cancer, it was total thyroidectomy for all cases. But we do know that total thyroidectomy has an impact on the quality of life. The total removal of thyroid surgery, with thyroid tissue with surgery. So we talk about hemithyroidectomy, but I will firstly try to invite you to concentrate on the suspicious case. So these are those patients which come to our outpatient clinic with their fine needle aspiration biopsy, telling that they have a suspicious nodule. Well, a hemithyroidectomy is quite possible in a neoplasm with atypical features, which is generally follicular neoplasm, or suspicious for cancer. So this is a procedure which we can carry out. A total thyroidectomy may be reserved for additional indications like multinodular goiter or Graves' disease. Turkey is a very huge country with a lot of patients with multinodular goiter. So generally those patients, even they are suspicious, if it is not a solitary nodule, they generally receive total thyroidectomy. What about regarding cancer? These are those patients where we did carry out total thyroidectomy, but recently, if the cancer is unifocal, if it's a small tumor, as sub-centimeter, or even a T2 tumor, a tumor with no extrathyroidal spread, no familial disease, no evidence of lymph node involvement, no angioinvasion, with no distant metastasis, a hemithyroidectomy will be sufficient. Because we very well know that with total thyroidectomy, when we compare it with hemithyroidectomy, the complications are higher. Oncological benefit with total thyroidectomy reaches out to 50 to 100 cases, 1 out of the 50 to 100 cases, and there is exactly a risk of harm. If we compare it with the statistics, we can see that 1 out of the 88 to 50 cases, again, suffers from some complications. Everything is very well described in the ATA guidelines, which are based with the evidence, the highest evidence base we have that have reached today. So if we come up for those patients who need surgery, if it's a thyroid cancer, bigger than 4 centimeter with gross extrathyroidal extension, clinical apparent metastatic disease to the lymph nodes, if it's a patient with distant metastasis, then we carry out a near total or total thyroidectomy. If it's a case which has a cancer between the 1 to 4 centimeter, without extrathyroidal extension, without clinical evidence of any lymph node metastasis, then either procedures are preferred, near total or total thyroidectomy or a unilateral thyroidectomy. I advise those specialists to carry out the agreement regarding the surgical management of the patients with your multidisciplinary team. Because, for example, in Turkey, it's not very easy to operate a 3 centimeter thyroid cancer with a hemothyroidectomy. So generally, we go for total thyroidectomy. But if it's a lesion which is under the 1 centimeter, it has no lymph node metastasis in the central or lateral area, then we generally perform a thyroid lobectomy, which is also advised by the ATA guideline, as we see here, a thyroid cancer under the 1 centimeter without extrathyroidal extension, the initial surgical procedures should be a total thyroidectomy, unless there are clear indications to remove the contralateral lobe, which is actually describing a possible other nodular formation or a parenchymal disease like Graves, for example. But it's very important to underline that this is a strong recommendation. So thyroid lobectomy alone is sufficient treatment for small unifocal intrathyroidal carcinomas in the absence of prior head and neck irradiation, familial thyroid carcinoma, or clinically detectable cervical lymph node metastasis. So that's why it's very important to have all these clues in the anamnesis of the patient in the preoperative workup. That was coming out from 2015, which is now prepared for being updated in the next coming years. I invite you to come to Rome, to the World Thyroid Cancer Congress, which happened in Italy. And there we discussed whether thyroid lobectomy is okay for the treatment of differentiated thyroid cancer. Absolutely, yes. Lobectomy should be preferred. Bilobal, but even bilobar nodular formation may warrant total thyroidectomy, but lobectomy is not a faulty choice. For example, if you have a 3 millimeter, 4 millimeter cystic nodule on one side, then it's quite possible to carry out a hemothyroidectomy on one side. So you concentrate on the cancer more than the subcentimetric cystic benign nodule. A solitary nodule with risk factors requires total thyroidectomy. So this came out of that panel. What about central lymph node dissection? If we talk about central lymph node dissection, all we who carry out the central lymph node dissection, we emphasize that it's very important to standardize this. It should be a dissection of the prelaryngeal, pretracheal, and at least at one side, paratracheal lymph node dissection. I know that we all know the fashion of lymph node spread. If we have a tumor in the thyroid, it's generally first to the central area and then to the lateral area. And that's why we have a very pressure of our endocrinologist colleagues, and they generally want us to do a central lymph node dissection if they have a patient diagnosed with thyroid cancer. But this procedure is not that innocent than we think. We do the dissection here, for example, this part is the head, this part is the body. Here we have the trachea. Here we have the recurrent laryngeal nerve. This is the esophagus. This is the inferior thyroid artery. Sorry. This is the upper parathyroid. This is the cleaned central area. And as you can realize, there is no inferior parathyroid tissue. So we took it out and we autotransplanted it in this patient. But this is the standard way of doing the dissection. And it's very important to know that lymph node dissection, central lymph node dissection on the left side is totally different than of the right side. At the right side, we had to dissect also the retronerval area, while we stay antenerval on the left side. So it's different, and it's a complicated procedure. So I already underlined the importance of the standardization of it, and that it's not innocent, and that experience definitely matters. If we have a doubt about having a lymph node, whether it's metastatic or not, if we have the possibility to go for frozen section, we generally go for frozen section. The benefit in terms of improved disease-specific survival or recurrence-free survival is not proven with prophylactic central lymph node dissection carrying out in every case. We say no for patients who without clinical or radiological evidence of lymph node involvement, who have all of the following characteristics: a classical type of PTC, papillary thyroid carcinoma, a female who is younger than 45 years, a patient who has a unifocal tumor, a intrathyroidal tumor which is not larger than 4 centimeters, no extrathyroidal extension, no involved lateral nodes. So why do we do the prophylactic lymph node dissection? This is also addressed by the ATA. They definitely, with strong evidence, do suggest therapeutic lymph node dissection. That's okay. So there's no judgment about that. And regarding prophylactic central node dissection, if you have a T3 or T4 tumor, or any tumor with lateral lymph node dissection, prophylactic central lymph node dissection is advised. A tumor, which is T1, T2, so a tumor under the 4 centimeter total interparenchymal with no evidence of central node metastasis in the preoperative workup or intraoperative workup, then you do not do your central node dissection, because the risk of complication is definitely higher, even you're an experienced surgeon. And actually, the number of dissections to benefit for one case regarding the prognosis or any recurrence, actually, it's 21 out of the 20 to 31 cases, not more. This is what we have seen during our study. It's a long follow-up study. We recruited 2 groups, total thyroidectomy plus prophylactic dissection, 2 total thyroidectomy. There was 1 professor who did the prophylactic thyroidectomy, the dissection in all cases, and the recurrence was the same. Regarding lateral node dissection, prophylactic, no. But therapeutic, definitely yes, but we have to confirm it with the FNAB or the frozen section. This is, of course, for the papillary thyroid cancers. But for those surgeons who are now listening, level 1, 2B, or 5A are generally the stations where the thyroid cancer do not metastasize to. So we leave it to generally level 2, 3, 4, and 5B. So this depends, of course, on the preoperative ultrasonographic workup. We even can do a compartment-oriented dissection, which can be, for example, only level 3 and 4 dissection. But this doesn't mean, of course, a berry picking, just taking out the metastatic, only one metastatic lymph node. So it's very important to underline the importance of compartment-based lateral lymph node dissection. Hypocalcemia and vocal cord paralysis is always pronounced in our textbooks, like especially the permanent complications, like 1%, 2%, or not more than 3%. But regarding the auditing, which the registries, which come out from generally from the European countries, we see that it's more than expected. These are the rates of the permanent hypoparathyroidism after total thyroidectomy, which reaches to 12% in England, for example. So it's not 2 to 3%. And as endocrinologists, you very well know that patients really suffer from hypoparathyroidism, and we still try to find a cure for them, which is still not available. A lot of things depends, of course, to us, because there may be a thermal damage. The gland may be devascularized, a hematoma may occur, a tying of the inferior thyroid artery may be very possible. That's why we invite the surgeons to try to be very close to the thyroid parenchyma, the capsula, during the dissection. And if you remove it incidentally, even you have not seen it, you always think about it and try to explore the tissue before giving it to the nurse. And if you see any parathyroid on it, please implant it. We always have to remind ourselves the localization and the variations. Good exposure is very important. So that means good light and operating under magnified loops. A meticulous dissection is warranted, and effective hemostasis. So this is very classic. But we always have to remind us to ourselves that we have to autotransplant the tissue. I know that on the other hand, during our, the philosophy of surgery is regarding the parathyroid. If there's one parathyroid, this is okay to, for the state of euthyroidism, parathyroidism. But this is actually not guaranteed. So what we say in our operating room to our resident, the parathyroid which you see, always keep in mind that it is the last parathyroid that you see, even you may discover 3 afterwards during the surgery. Even the surgeon is very experienced, even he or she is thinking that he or she is very experienced, we still need some identification for the parathyroid. So we need an adjunct in the operating room that we have protected the parathyroid, that we have protected its vasculature. So that's why today we invite the autofluorescence system to our operating rooms. It's very new in Turkey as well, but it's also true for the whole world. So there are very few centers which use it in daily practice, but it will come in our operating rooms very shortly, I believe. And the literature regarding autofluorescence is still very infant, so we still need more data to convince ourselves as well. Another possible complication was the harming of the laryngeal nerve. Intraoperative nerve monitoring is very helpful during surgery for navigating the nerve and for confirming its function. So it's a system which visually and electrically detects the recurrent laryngeal nerve. Of course, it's not a substitution for our golden standard. The golden standard is seeing the nerve during the operation. I remember some of my old senior professors who did carry out the thyroid surgery without visualizing the nerve, but this is not true anymore. So during our global description of thyroidectomy, we always invite the surgeons for visualizing the recurrent laryngeal nerve. The nerve monitoring is just an adjunct, which is helping us may help us in navigating the nerve, but definitely it helps us with describing its electrophysiological function with the feedback of the system. We use it especially in the difficult cases, which are generally those cases where central lymph node dissection has been carried out, the thyrotoxicosis patients, thyroiditis, retrosternal large goiters, and especially the redo cases. We do know very well, but with the use of IONM, with nerve monitoring, the recognition of the nerve is increasing. And this is especially true for the residents. Anatomical intact nerve does not mean a preserved nerve. We will see later on why it is like that. But why it is important to detect a nerve? It's important because it has an impact on prognosis. It's not the prognosis on the thyroid cancer, it's the prognosis on the nerve. we stop the surgery and we protect the case from a bilateral vocal cord injury. It defines the site of injury. And if we have, for example, a worse voice outcome after surgery, we definitely know whether it's to the nerve injury or any injury during the tracheal intubation. And with the help of the nerve monitoring, we definitely it helps us to protect the nerve with changing our maneuver during surgery. That's why we like it. There's a very nice study from Germany. They randomized to, they have two groups. In one group, in both groups, nerve monitoring was used. In one group, they didn't change the strategy after loss of signal, which means a possible recurrent laryngeal nerve palsy, temporary or permanent. But they had bilateral paralysis in that group. While they changed their strategy, they stopped the surgery, they do just one side surgery, and they had, of course, zero bilateral paralysis, which is very important. Here I try to understand, to explain you what it happens. This is what we do during surgery. Traction to the thyroid tissue and traction to the recurrent laryngeal nerve happens, which is generally the main reason of laryngeal nerve injury, as you see here. This, of course, invites some medical legal issues as well. Bilateral patients that suffer from bilateral laryngeal nerve surgery, and this, of course, reflects to the economics, and this, of course, reflects to the lawsuiting. So surgeons using with the IONM, we know that today they have a lower risk for lawsuiting. We have a very nice study published in Turkey, those cases with bilateral nerve problem, they went to lawsuiting, and all of them, all 32 cases were addressed to be malpractice instead of complication. So that's why I think it's very important to describe the electrophysiology of the nerve as well during surgery. And this is what we see that the lawyers also seek for, or the judge is seeking for during the surgery. So the use of nerve monitoring is increasing worldwide. This is the numbers of Asia. This is very specific to China, but this is also true for Turkey. For example, we started in 2012 with a very less centers. Now we have an incredible increase in those cases where we use the interpretive nerve monitoring. But we still have no level 1 evidence. To reach level 1 evidence, we have to recruit millions of cases, so which is actually not possible. But what we do very well, know very well, that the nerve injury is higher than we do expect. So it's very important to use the nerve monitoring system, especially in the high-risk case, in cancer cases, for surgeons who have a low volume, because we definitely know that they have an impact on lowering the risk of the recurrent laryngeal nerve injury. We're talking about registries. I think it's very important to describe outcome data of registries, because there is actually no bias. This is not a one-center or two-center study, and it's pooling a lot of data from those centers who do this type of surgery or whatever. So this is coming out from the Scandinavian registry. They had a palsy rate of 4%. The nerve monitoring use was 62%. So in 38%, there was no use of nerve monitoring, but there was a definitely higher rate of recurrent laryngeal nerve injury in the group where nerve monitoring was not used. And there was definitely no bilateral palsy in the group where nerve monitoring was used. This is a very recent study which had been published in the BGS, which comes out of another surgical registry called the Eurocrine. The nerve monitoring use is much more higher here, 91%, and it pooled nearly 4,500 cases. And the use of nerve monitoring was definitely associated with a lower rate of postoperative vocal cord palsy. So this was regarding the possible complications, which is actually higher than we expect today. So we do try to have to do everything to lower this. It's very important to actually read what we always say, and this is one of the recommended readings for your platform, which I learned yesterday from Professor Washak-Matse. So I think it's very important to standardize the treatment on our local platform and to share our knowledge internationally. To conclude, thyroid cancer incidence is definitely increasing. So we will have more patients than we have today, I think. But we always have to think that hemothyroidectomy is effective. Central lymph node dissection is there, should be there, but only in selected cases. We have to remind ourselves that surgery, even it's available, it's not without risks, and the adjuncts are helpful to the success of surgery. I thank you very much for inviting me, and I welcome your comments.
Dear Ozer, thank you so much for this excellent talk yeah, very informative lecture. I think we have a question, so I will go directly to questions, and thank you once again for your congratulations regarding the guideline, where we are really very proud of this achievement. And now the questions, I will read questions in Georgian just for our colleagues, for all to understand the question, and then you will have a simultaneous translation in English, okay?
Okay.
Well, ქართულად წავიკითხავ შეკითხვებს. ნინო ნადირაძის შეკითხვა არის. დიდი მადლობა საინტერესო მოხსენებით. ჩემი კითხვა მდგომარეობს შემდგომში. პაციენტს, რომელსაც მანამდე დადგენილი ჰქონდა აუტოიმუნური თირეოიდიტი და აღმოაჩნდა კვანძი, ასპირაციით B-ტესტ და 5, რა მასშტაბის ქირურგიული ჩარევა იქნებოდა რეკომენდებული იმის გათვალისწინებით, რომ პაციენტთან აუტოიმუნური თირეოიდიტია?
I don't have the translation, but now I take on English. I realized that I have to take it. I was off. Can I have the question once more? Okay. This is, of course, a very, hot topic question, actually. I thank very much for this question. I think this is something related to discuss with the patient, because on one hand, you have a diseased tissue. On the other hand, you have a thyroiditis, where the patient may suffer from a complication regarding bilateral surgery. So I definitely know very much that the endocrinologist generally is asking for total thyroidectomy, but having an autoimmune thyroiditis, regarding only thyroiditis, this has no, indication for surgery, only for very special cases. Mm-hmm. So if it's about the nodule, a suspicious nodule on one side, and it's FNAB5, then we go generally for, if you have the possibility of frozen section, go for frozen section. If no, hemothyroidectomy may be sufficient. But of course, we have to inform the patient that already they are on the LT4, so the thyroxine supplement replacement. They still will be on it, or they may receive higher doses. So I think this is depending on your dialogue with your endocrinologist and with the patient. Thyroiditis, it's not innocent. It may be a very easy operation, but may be also a very catastrophic operation. And if you do harm the recurrent nerve on the other side, or it happen, or a hypoparathyroidism, a permanent hypoparathyroidism may happen, then you try to ask yourself, why didn't I stay on one side? So this is very important. And here the use of neuromonitoring is again very important, because you have a lesion on one side, you have a parenchymal disease for both sides, and you definitely should know whether the nerve on that side is working or not.
Okay, thank you. Well, next question. Ქართულად გავაგრძელებ. გავაგრძელებ შეკითხვების წაკითხვას ქართულად. ნათია ბარამიძის შეკითხვა არის, მაინტერესებს რა შემთხვევაშია უკუნაჩვენები თიროიდექტომია და ნერვის დაზიანების შემთხვევაში გამოსავალი რა შეიძლება იყოს? ანუ ორი შეკითხვა არის რეალურად, უკუჩვენებები და ნერვის დაზიანების შემთხვევაში როგორ ვიქცევით?
Sorry, I couldn't get the question. Can you repeat it once more? Okay, actually, I think Professor Vashakmate is asking surgery in the advanced cases, because generally, if the patient is fit for surgery, there is actually no contraindication. But if the patient has, distant metastasis, which is not controllable, which is not isolated on one organ, then thyroidectomy, even in that case, thyroidectomy is not contraindicated. Please, if I misunderstood you, please correct me, because I don't want to have that you have a wrong message. On the other hand, if we have one case during our surgery, if we have a recurrent laryngeal nerve during the surgery, definitely do not go to the other side. Even this is debatable. Generally, the surgeons, whether it's a survey or whether it's, what happens in real time, real life, we do stop the surgery and we go for a two-stage surgery. Harming the laryngeal nerve doesn't mean that it's permanent. It may be temporary harming the nerve. So it's a temporary injury. Then we even may wait 3 to 6 months, which has no disadvantage regarding the oncological point of view. So we stay in close touch with the patient. We try to see what is happening. We see the outcomes of the pathology, and then with the multidisciplinary team, we try to define the next step for the patient.
Well, thank you. The next question is Temur Gogitidis შეკითხვა, მის ქართულზე გადავიყვან. Temur Gogitidis შეკითხვა არის ძალიან ქირურგიული შეკითხვა არის, რომ მაინტერესებს თუ იყენებს ბატონი ოზერი ლიგაშულს ან ჰარმონიკის დივაისებს იმისთვის, რომ შეამციროს კვანძების დადების დაჭიროება, თუ კვანძავს ზედა ქვედა სისხლძარღვოვან კონებს, თუ საკმარისია მხოლოდ კოაგულაცია. ნამდვილად ძალიან ქირურგიული შეკითხვა არის. Coagulation. The coagulation.
Okay. I think it was a long question coming from one of our surgical colleagues, and it was not easy to translate. But as far as we understand it, our colleague is asking whether we are using energy-based device or we are just classical tying. The energy-based device is there for every type of surgery. So I think this is a revolution for the thyroid surgeon, for the parathyroid surgeon, but also for other general ENT surgeons who use this type of surgery. But tying and knotting may be there for the major arteries, which is the arteriothyroid superior, inferior, but even for them, I use the energy-based device very safely. We do carry out thyroid cases, only thyroid cases, from 500 to 600 a year, out of the pandemic, of course, in our routine. But these devices spread heat. So we have to be very careful while using close to the parathyroid and close to the recurrent laryngeal nerve. That's why we prefer to tie when we feel that we are close to the recurrent laryngeal nerve and the parathyroid. Even a 3 millimeter safety zone has been described for these energy-based devices. I don't, I feel myself safer with tying close to those structures.
Thank you. Next question is from our colleague, surgeon. ბაკურარებულის შეკითხვა არის. ბატონი ბაკურის შეკითხვა არის. მადლობა მოხსენებისთვის. ინტრაოპერაციულ მონიტორინგთან დაკავშირებით მაინტერესებს თუ აკეთებთ რუტინულად ზედა ლარინგეული ნერვის მონიტორინგსაც.
No. Yes, I use it in every case. It's expensive with the tracheal tubes. We have electrodes which surround the tracheal tube, but alternatively, we may use needle electrodes, which we position in the perichondrium of the tracheal cartilage. And this alternative makes it easier and more cheaper. So this is what we use since the last 2.5 years. We have hundreds of patients and we are very happy with using the needle electrode. So if you have the reimbursement of the patient pays, we use it, I advise to use it in every case. So even it's very helpful in the difficult case. Generally, those surgeons who use the nerve monitoring advise to use it in every case. And today I cannot do without using it because I really want to hear the voice, the signal, and to see the amplitudes, which, makes me feel better when I finish the surgery. And you can guarantee the voice outcome if the anesthetist hasn't intubated in a rough way. And it's also there for the superior laryngeal nerve because, it has also already a function on the phonation of the patient. So this is also very important. That's why we do it for the recurrent laryngeal nerve and for the superior laryngeal nerve. And it's very important to describe here the standards. What we have seen in the Turkish platform that nearly 1 out of the 3 surgeons, they do not check for the vagus nerve, but we have to check the vagus nerve. Otherwise, it is misinterpreted. So what we always say, if you do not check the vagus nerve, then do not use the nerve monitoring because you cannot convince the court if there happens any problem. And you cannot convince the experienced surgeon who used this instrument. So it's very important to go and check the vagus nerve, the recurrent laryngeal nerve, and also for the superior laryngeal nerve, which is already there.
Thank you, Ozer. There are lots of questions for you. თემურ გოგიტიძის შეკითხვა არის, უსტუდიეთ ქართულზე გადავრთავ. თემურ გოგიტიძის შეკითხვა არის. საინტერესოა ბატონ ოზერთან კლინიკაში ვინ აკეთებს ფარისებრის ბიოფსიებს? ბატონ თემურს რატომღაცა ჩვენებებთან დაკავშირებით აქვს დამატებით კითხვები და ვინ იღებს ბიოფსიის საჭიროების შესახებ გადაწყვეტილებას?
That's a very good question. Surgeon-performed ultrasound and biopsy is quite possible, and this is also described in the literature. I have colleagues who do it, but I don't do it by myself because if we had time, maybe we could learn and do it, go for it. Even we have learned it, we do not go for it because we do not have time for it. But we have a very good team. I rely on the team. I rely on the, on our connection and our energy. And we do see that the patient doesn't suffer from losing time. That's why our radiologists do it under ultrasonographic guidance. Our endocrinologists can do it. They also have an ultrasound, and ultrasonography is also in their curriculum. So every endocrinologist raised up as an endocrinologist gets know very well the ultrasound and the ultrasound guided fine needle aspiration. It's very important to check the quality, of course, of what you do, and the non-diagnostics outcome is not more than a few percent for the endocrinologists and for our radiologists. So we rely, and because of the good connection, they do it, and we never, looked for it to do, but it's not wrong, of course. It's not true just to palpate and go for a needle. This is not right. It should be definitely under ultrasound guidance. I think this is the most important thing to underline here.
And who made the decision?
Decision? Well,
this was the question also. Okay,
yes, sorry. We have two outpatient clinics in our academical center. One is endocrinology, one is endocrine surgery. We generally do not like to serve for those patients who actually have to apply for endocrinological clinic, outpatient clinic. So it's generally those patients who are advised for surgery and who come for consultation for surgery. So that's why it's not the endocrine surgery clinic, but dominantly it's the endocrine clinics, outpatient clinics. So they are those who are generally asking. But professionally, I have patients who ask me to manage or, or ask my opinion whether to go for fine needle biopsy or not. Of course, I can give it. So I think there shouldn't be a fight between the endocrinologist and surgeon who should do it. Exactly. Just do it regarding your standards. This is very important. We do not biopsy a cystic nodule, and I seek for a very good qualified ultrasound. This is very important. So it's not a nodule, put the needle in it. That's not right. We should go in a very standardized fashion and do all the same standardized thing, actually.
დიდი მადლობა. შემდეგი შეკითხვა არის ედიშერ სიხარულიძის. მადლობა, მაინტერესებს თქვენი აზრი ონკოპლასტიურ ქირურგიაზე, ისეთ მეთოდებზე, როგორიც არის ტრანსორალური თიროიდექტომია. რა თქმა უნდა, ედიშერ სიხარულიძის შეკითხვა არის ქირურგის. მაინტერესებს ონკოპლასტიკურ ქირურგიაზე, კერძოდ ტრანსორალურ თიროიდექტომიაზე. აზრი, პროფესორ ოზერის აზრი.
About what surgery? Sorry.
Transoral thyroidectomy.
Okay. So as far as I understand, I am asked my opinion about transoral surgery, right?
Yes, exactly.
Okay, because there was something about anaplastic, something like that. All
And
right.
an oncoplastic, like it's a plastic.
Okay, okay. It's quite possible regarding an oncological patient, for example. A very suitable patient for transoral surgery is a solitary nodule, a patient with a not very long neck, with a very short neck, a subspecial or biopsy-proven papillary thyroid cancer without lymph node metastasis in the lateral side. It's quite a good candidate for transoral surgery if the patient wants it, of course. So these are generally those cases where we may advise or who do look for transoral surgery. But it's very important to underline that the only superior outcome of transoral endoscopic surgery is having no scar in the neck. So it's a surgery carried out with the underlip, 3 tunnels via the underlip. We reach the thyroid area, we take out the lobe. So this is what we do, and the only superior outcome is having no scar, and that's all, with the same fashion. Generally, when we give a talk about transoral endoscopic thyroidectomy, we are asked whether central lymph node dissection is possible. Yes, it's possible, but it's easier on the left side, as I pronounced you during my speech. It's a little bit can be hazardous on the right side, because on the right side we have to also go retronerval, and it's not very easy with those endoscopic instruments to go under the nerve and dissect it without causing any bleeding. And here the robot, for example, comes out with its superiority. And the lymph node dissection, I mean central lymph node dissection with the robot, is definitely easier compared with the traditional endoscopic instruments.
Mm-hmm. Well, ესე იგი თამარ-სარალიძის შეკითხვა არის, როდესაც კვანძი მჭიდრო კავშირში არის შებრუნებულ ნერვთან, კვანძის სრულად ამოკვეთის შემთხვევაში ალბათობით ნერვის დაზიანების ალბათობა მაღალია. ამ შემთხვევაში თქვენი ქირურგიული ტაქტიკა როგორია?
Okay, this is a wonderful question. If it's a papillary thyroid cancer, we do very know that we have also a very important adjunct, which is radioactive iodine. So we always have to think about the quality of life of the patient as well. So if we have a case, even a recurrent laryngeal nerve is involved, we try to shave it with protecting the integrity of the nerve. So this is very important. I know that the surgeon doesn't feel himself or herself, very okay, because we are always telling ourselves to do the R0 resection, which means leaving nothing, no tumor behind. But even we leave some microscopic on the nerve with the intent of protecting the function of the nerve with shaving, then you may leave the rest to radioactive iodine, not radiotherapy, radioactive iodine. And during the follow-up, you will see we have a lot of patients who had the invasion to the recurrent laryngeal nerve. We did our best to protect the nerve. It was even, we had, this is the tumor, this is the nerve, it goes in. We opened the tumor. We just, try to dissect it around it with protecting the nerve. So it's just, when you see this, just cut the nerve. I don't think we should do it like that. We should try to do our best to protect the integrity of the nerve if it's about a papillary thyroid carcinoma case?
Well, შემდეგი შეკითხვა არის ქალბატონი მარინა გორდელაძის. ქალბატონი მარინა გვეკითხება, მოგესალმებით, რას გვეტყოდით ბავშვებში ფარისებრის კვანძებისა და სიმსივნის თავისებურებების შესახებ?
No. Yeah, this is absolutely a wonderful question, and during our lectures we always tell that when compared an adult with a child, a nodule in a child in the childhood has definitely a higher risk of thyroid cancer. It reaches 50% of risk. So that's why we have to evaluate carefully a child who is admitting our outpatients with a nodule. So, but regarding surgery, of course, the parathyroids and the recurrent nerve is more vulnerable than the adult patient, as expected, of course. So that's why we have to be, more and more meticulous during the surgery. But regarding, the presence of nodule is definitely a higher risk compared to the adult.
Next question. Maya Torchinavas შეკითხვა არის. მაინტერესებს რეკურენსის პოსტოპერაციული დაზიანების შემთხვევაში მკურნალობის და შემდგომი რეაბილიტაციის პროცესები ვის მიერ იმართება და დროში როგორაა წარმოდგენილი?
No. Yeah, okay. Again, a perfect question. Thank you. If you realize that you have damaged the surgery, the nerve, it's important whether it's anatomical intact or not. If it's anatomical intact and you have no, electrophysiologic feedback, then possibly you will have a vocal cord palsy as well. But whether it's permanent or whether it's temporarily, we do not know. So in the very first step, it's very important to stop the surgery on one side. This is one. The second one, if we have disrupted the nerve, then try to do the anastomosis. I know it may sound weird because it's a very tiny, tissue, but even we do it, we do know that we protect the larynx muscles from going to atrophy. So having some function, even not in a very smooth and regular way, there is some electrophysiological flow from the nerve to the larynx, which protects the larynx muscles going to atrophy. Thirdly, if we have loss of tissue and we cannot do the anastomosis, we still can use some nerval structures from the lateral neck, which is, for example, the ulcer cervicalis. One point of the cervicalis may get to the recurrent laryngeal nerve to be anastomosed. So this is what we have to do during the surgery. And secondly, in the postoperative workup, it's very important to have a very close connection with your ENT fellows, because
ENT, what is the ENT?
The ENT is ear, nose, throat. I do not know how you say it. Yes, because the ear, nose, and throat surgeons, the head and neck surgeons, or the otolaryngologists, actually. So we consult those patients in a very early phase because they are very happy to start the speech therapy in the very beginning, to give the exercises to the larynx to have the most good voice outcome in a more earlier time. And during these follow-up, they always check the recurrent laryngeal nerve, whether there is any movement or any progression or regression. So the otolaryngologists do the follow-up, but it's very important as a surgeon to be with the patient. You know, it's what I have seen in my follow-up. This is for our young colleagues here on this platform. If you stay in very good and close contact with your patient, if their sorrow is your sorrow, it's generally you never suffer from it. They are always very thankful, whatever the prognosis of the situation is. So this is very important. It's just, okay, this happened and go to the otolaryngologist. No, this is not right. As long as you stay with the patient, it turns out good according on your side, and you have the possibility to, you know, see the follow-up, what is going, and generally it's going in a good way, because with this, even with the speech therapy, a lot of patients do good.
Okay, and Ozer, do you in Turkey use vocal cord injection augmentation techniques?
Yeah, this is of course, this is for the otolaryngologist, but this is left to the, you know, there are step by step they go, what I see. And generally with speech therapy, everything, the voice outcome is going better. But in some patients, you know, even all those injections, they may be done. I know that they do it, but you know, they have good outcomes. I know it as well, but it's there, yes. But I have no personal experience regarding it.
Me too. And I have few questions personally, and would like to use this opportunity to ask the questions regarding the hypoparathyroidism, because my talk after your presentation is about hypoparathyroidism, and I just wonder if you in Turkey use, and in your department use, prophylactic calcium and vitamin D cholecalciferol supplementation after surgery, or you measure calcium trends or PTH, and then discuss or decide to give supplementation or not. What is your strategies?
Okay, great. This is a wonderful question. And what I realized that every center has its own management, and we still do not know what is the best. That's why we are always debating, talking, and this is like a never-ending story. What we do is, this is not a day surgery, but this is a one-night stay surgery. So if you do the operation in the morning or in the afternoon, in the morning, I ask for a calcium check. I can check for the PTH, but it's expensive here compared to calcium. Mm-hmm. I do the Schwostek. I ask for, of course, for these symptoms, and I do the Schwostek, and I don't go for the trousseau, and I just compare my outcomes with the calcium outcome, and if it's not lower than 8, I do not. Yes, I do not advise the patient to have intravenous calcium, but if it's no symptoms under the 8 milligram deciliter, then the patient will receive calcium just once, because they are discharged in the morning. But every patient, while going home, they receive a receipt with calcium with inactive vitamin D. So it's just a, you know, a tablet. I know that you have it there as well, twice a day. But it's just, if it's not a permanent hypo case, we expect generally in surgery, it's described between 15-20% to 35%, the temporary hypoparathyroidism. So because we do not want them to suffer from this, prophylactically, we advise them twice a day calcium plus vitamin D. But vitamin D is inactive, not the active. So it's just one tablet they put in water, you know that. So, and after 1 week, during the follow-up, I asked them to lower the dose to 1 and then to quit it after 1 week. So it's just 2 weeks, calcium and vitamin D supplementation, not more.
Okay. And Ozzer, do you use so there are when we were on Parrot meeting last year, probably there was a discussion about autofluorescent method to identify parathyroid glands during surgery, and therefore decreasing the chances of parathyroid damage and hypoparathyroidism. Do you use or work with such techniques?
Yeah, this I want to, because now we have we have 2 systems. There are 4 systems. I haven't used it. There are 2 different systems actually, but the most relevant one is that shows the vascularization as well. So it's important not to see only the parathyroid, but also to convince yourself that it's good vascularized. And the system which we are going to use, it's still not in Turkey. It's somewhere at the border. I do not know, but in the very near time, we will going to use this. Try to use it first, and then try to use it in every case. But we are dependent on technology and on autofluorescence. So both have to be available. And the good thing is there are 4 or 5 systems on the market, and that means that it's not going to be that expensive. But I guess that it's going to be an important adjunct in the operating room, because it's definitely the rate of hypoparathyroidism is definitely higher than we describe in our papers or what we read in the textbooks.
And my last question, and yeah, we will let you go. Regarding the thyroid nodules with the Bethesda 4. So when there is a suspicious for follicular neoplasia, what is your tactics? Generally, it is recommended to do a diagnostic surgery, but do you use the modern genetic profiles, molecular profiles, to identify patients who need surgery, or to identify the nodules that could be actively just followed up without surgery?
Yeah. Thank you very much, Natia. It's an excellent question, but there is actually a general agreement maybe here for follicular neoplasms that we go definitely for surgery. Genetics may help, but it's very important to know the BRAF mutation level in the normal on your geographical ground, which is, for example, 70% for the Koreans, which is 33% for those people who live in the Izmir region here. This is coming out from one of our studies, which we carried out with our oncologists and endocrinologists together, that normal people, those patients who underwent operations due to multinodular goiter and who were really benign cases, 33 was BRAF positive. So we do not know how to react actually, but on the other hand, the cost of genetic screening today is $4,500 here. So that's definitely very expensive. So It was 1 or 2 cases in a year who asked for genetics, but now it's no case who asks for genetics. They read it in the internet, they know it's there, but neither the patient nor the physician is going generally ask for the genetic screening. So it's surgery definitely for those cases. And the most questionable thing is to go for frozen or not for those patients. Generally, we do carry out a hemithyroidectomy, but let the patient know that they may require a completion thyroidectomy, but completion thyroidectomy comes out just 1 out of the 10 cases in those cases. But if you have a very experienced pathologist who is only looking at thyroid pathology, then sometimes they can be helpful during surgery with frozen section, but I do not advise go for frozen section in those cases. I just want to let you know, if you are as lucky as I am working with a thyroid pathologist, where you can, discuss everything and you can understand each other, then you may go for frozen section.
Okay. So, Ozer, thank you once again for
Thank you, Didi Maglova.
for your time, for joining us. It was a big honor for us to have you with us, and thank you for your brilliant presentation and your expertise you shared with us. Thank you once again.
Thank you very much. It's my honor, Didi Maglova, and great success. Bye-bye.